Alterations in integument, pathophysiology and management. The skin is defined as an organ that covers body surfaces. It consists of two distinct layers, the epidermis and the dermis. The epidermis is the outermost layer that covers the dermis and is continually replaced every 35 to 45 days. It produces melanin, which is a dark pigment that helps determine the color of the skin, and that's stimulated by strong ultraviolet light, such as what we find in sunlight. The dermis is a strong connective tissue that contains elastic fibers, blood vessels and nerve endings, and sweat and sebaceous glands, along with hair roots. It also creates ridges that form a unique pattern of finger, palm, and footprints and facilitate the ability to grip and hold on to objects. Then subcutaneous tissue is skin that's attached to muscle, bone, and is made up of connective tissue and fat cells. Hair will originate in the hair follicle in the dermis. There's two types of hair, vellus and terminal. Hair is composed of keratin and amino acids. The scalp hair is going to grow the most rapidly, but all hair growth is going to slow by midlife, and decreased melanin production will cause graying hair. The sebaceous glands are connected to each hair follicle and they secrete sebum, which is an oily substance that helps prevent the drying and cracking of hair and skin, and it's more active during puberty. There's two types of sweat glands. We have the eccrine glands, which release water and electrolytes in the form of perspiration, and the apocrine glands, which produce cerumen. This is going to perform no real purpose in the human. Nails will form hard layers of keratin, and they also have a protective function. The nail root itself has an abundant capillary blood supply, and the lunula is going to be the portion that is the active growing base. The skin will perform its protective function by shielding underlying tissues from trauma and pathogens and by preventing excess loss of fluids. It helps regulate temperature by altering the diameter of the surface blood vessels and through sweating. In other words, through vasodilation and vasoconstriction. The body loses heat through radiation, conduction, evaporation, and convection. The skin has many sensory receptors for touch, pressure, pain, and temperature. Ultraviolet rays in the sunlight will activate a substance in the skin that will eventually be converted into vitamin D. The skin contains an extensive blood vessel network that can store as much as 10% of the body's total blood volume. So, true or false? The epidermis is replaced with new cells every 35 to 45 days. The next layer, the dermis, contains the ridges that comprise the fingerprints. This is true. Okay, so again, true or false? One of the primary functions of the skin is to protect underlying structures. Once again, this is true. One of the primary functions of the skin is to protect those underlying structures in addition to protecting from pathogens and also from dehydration. Again, true or false? Apocrine glands are going to secrete fluid during perspiration. This is false. They secrete the substance in the external ear canal called cerumen. In animals, those apocrine glands will secrete pheromones. Regardless of the condition, it is important to perform a complete assessment. When you're looking at the health history, look at the medical diagnosis. We have to have a complete health history and physical examination for all issues. Look at the chief complaint and the history of their present illness. Do they have discomfort, pruritus, color changes, lesions, hair loss, or abnormal hair growth? When did this start? Did anything precipitate it, or does anything alleviate it? Look at their previously diagnosed skin diseases or problems, current and recent medications and allergies. Do they have a history of diabetes mellitus, cancer, kidney failure, thyroid disease, liver disease, or anemia? A change in their skin color or pigmentation, a change in a mole, sores that are slow to heal, itching, dryness or scaliness, excessive bruising, rashes, lesions, hair loss, unusual hair growth, or changes in their nails can all indicate some underlying disease process. Look at their past and present occupations, their exposure to chemicals or other irritants, skincare habits, sun exposure, recent changes in their work or living environment, and current stresses or sources of anxiety. Determine the nutritional status by questioning the client about their intake, and we can also obtain some labs such as albumin, prealbumin, creatinine kinase, creatinine, myoglobin, and potassium. We do know that vitamin A is required for healthy skin, and we're going to find these in liver, avocados, pumpkin, sweet potatoes, carrots, spinach, broccoli, cantaloupe, and apricots. Poor nutrition or fluid intake can result in cracked skin, dermatitis, dry skin, purpura, petechiae, or poor wound healing. When you're doing your physical assessment, make sure that you have adequate lighting so you can see everything that you need to see. Assess the skin for smoothness, coloration, intactness, temperature, and hydration. The skin should be free of lesions. Assess for hair, color, distribution, and texture. Observe for any abnormal findings such as nits, lice, scaliness, or flakiness. And assess the nails for normal structure, variations in shape, thickness, color of the nail bed, and capillary refill. This slide shows different types of lesions that you may encounter throughout your nursing career. There's 4 main descriptions for skin color. We have pallor, which is pale or white, and in brown-skinned people, it might be yellowish brown. Ashen might be found in black-skinned people. We might need to observe the skin color in the mucous membranes, lips, or nail beds in the darker colored people. Erythema is pink or red. Cyanosis is blue. And jaundice is golden or orange-yellow color. So how do we assess a wound? You have to use your senses when you assess a wound. What does it look like? Look for color, swelling, exudate. Is it warm to touch? Is it soft? Is it boggy? Is it firm? Etc. Does it have an odor? Now, we don't determine odor by pulling off an old dressing and then smelling the dressing, because it is going to have an odor when you do that. It's set there for several hours anyway, if not several days. So you have to cleanse the wound, and then if there is an odor following cleansing, then we consider the wound to have an odor. Listen for complaints, moaning, groaning, catching of the breath, etc., to help assess pain. We measure a wound like the face of a clock. So look at this picture here. The head is going to be 12 o'clock, and the feet are going to be 6 o'clock. Your right will be 3 o'clock, and your left will be 9 o'clock. And if everyone measures according to the face of the clock or documents their descriptions according to the face of a clock, then everyone will be on the same page, so to speak. Up and down is always going to be the length, and we measure that first. Side to side will always be the width, and that is measured second. And then the depth is going to be the third measurement. So we measure the deepest point of depth by placing the tip of a cotton applicator into the wound base. And then we'll mark the level of the wound edge with our thumbnail on the applicator, and then we'll measure that on our ruler. Wounds are going to be measured in centimeters. Then we need to look for undermining and tunneling. Undermining is when part or all of the wound edge is not attached to the wound bed. So that means you can take a cotton tip applicator and you can actually run it under the edge of the wound, and there's some depth there. Tunneling is just what it sounds like. It's a tunnel into part of the wound bed. So to determine undermining, we take that tip of the cotton applicator and we run it around the wound edges, and we determine where the undermining is. For example, we have undermining from 1 o'clock to 5 o'clock, or we have undermining from 1 o'clock to 10 o'clock. That lets us know where the undermining is located. Then we determine the deepest depth of the undermining, and we do that the same way as we determine the wound depth. We take the cotton tip applicator and we find the deepest part of the undermining. We measure it with our thumbnail on the edge of the wound, and then we measure the depth of the undermining. We do the same thing with the tunneling. And when we find the tunneling, we describe it as to the face of a clock, and then we also include the depth of the tunnel. We need to identify the wound bed tissue. Is the tissue epithelial, granulation, slough, or eschar? If it's epithelial, this is a partial thickness loss and it's pink tissue. If it's granulation, it's a full thickness tissue loss and it's more of a beefy red color. It almost looks like hamburger. If it's slough, this is a full thickness skin loss. It's non-viable tissue. It's going to be yellow, white, tan in color, and it can be very moist. And it's usually pretty adherent to the tissue. In other words, it's going to look kind of snotty, but you can't wipe it off. Eschar will also be a full thickness skin loss, and it's usually black or dark brown, and it can be very hard and dry, or it can be soft and moist. We also need to assess the peri-wound, which is going to be the area around the wound up to 4 centimeters around the perimeter. We're looking for the integrity of the skin, the color. We're also looking for warmth and what we call induration. We need to also assess for edema, erythema, and varying warmth when we're documenting the peri-wound. We need to assess the exudate or the drainage. We need to know what type it is, how much there is, and is there any odor. So serous exudate will be clear or light yellow. Sanguinous will be blood. Serosanguinous is going to be a mixture of the two. It can look like watery blood, or maybe it's just blood tinged. Purulent will be opaque, and basically it looks like pus. It will probably be white to yellow to green. And we can also have a mixture of sanguinous and purulent, so sanguinous purulent drainage. We always assess for signs of infection, and that's going to include the erythema, the warmth, the purulent exudate, edema, and increased pain. And we always assess for pain, preferably using that numerical scale, but some clients are unable to verbalize. We may just see moaning or groaning, crying, yelling. We also need to watch their body language, such as grimacing or withdrawing when we touch the wound, or they may be guarding. A skin tear is a traumatic wound that's caused by mechanical forces, including removal of adhesives, as defined by the International Skin Tear Advisory Panel. There's several classification systems out there. I prefer those that are going to be the more simple to use, but they're going to provide continuity to wound descriptions. The new simplified International Skin Tear Advisory Panel classification is Type 1, which includes no skin loss. We have a linear or flap tear that can be repositioned to cover the wound bed. We have Type 2, which is a partial skin loss, a partial flap loss that cannot be repositioned to cover the wound bed. And if you look at the picture here, this is what I would consider to be a Type 2. Part of the wound bed is exposed and part of that flap has been lost. Type 3 is a total flap loss that exposes the entire wound bed. The International Skin Tear Advisory Panel also states that a flap in skin tears is defined as a portion of the skin, epidermis or dermis, that's unintentionally separated from its original place because of shear, friction, and/or blunt force. And these are the common causes of skin tears. They can occur on any part of the body, but usually on the arms or legs. They're particularly common in populations that have fragile skin, such as the elderly, chronic or critically ill, the neonates, and pediatrics. So to prevent skin tears, we have to create a safe environment for the individual that's going to minimize the potential of bumping into or knocking into furniture. When possible, in these high-risk clients, we need to pad and protect their extremities. We should maintain skin integrity through a consistent skincare regimen and proper nutritional and fluid intake. These clients may need to wear protective footwear and clothing to help reduce the risk of injury. We need to ensure safe client handling techniques are being used to limit the risk of injury. We should also avoid the use of adhesive products on frail skin. Treat it. The main goals are going to be to preserve that skin flap if possible and then protect the surrounding tissues. We should reapproximate the edges without undue stretching using a moistened cotton applicator. We should protect the site to reduce the risk of infection and further injury. And when we select a dressing to use on a skin tear, we should look for a dressing and medical adhesives that are going to allow for atraumatic removal, extended wear time, and moist wound healing. The bio-occlusive dressings are not recommended for skin tears. If the dressing is opaque, in other words, you cannot see through it, you should use an arrow to indicate the direction that the dressing needs to be removed so you're not going to disturb that skin flap. And then monitor the wound for signs of infection such as pain, increased exudate, swelling, heat, erythema, and odor. These are the different tissue types. If you look at the picture on the upper left, this picture has more than one tissue type. The majority of the wound is going to be covered by that light pink tissue, and that's epithelial tissue. So epithelial tissue is the partial skin loss. The darker red is going to be granulation tissue. The middle upper picture is a good picture of granulation tissue. The picture on the upper right is a picture of slough. Again, this looks like a a snot or wet scab, this tissue is not alive, it's dead, and it is most likely adherent to the wound bed. The bottom left picture is what we call eschar. It's dark in color. I can tell you by looking at it that it's probably dry. If you look to the left side, you can see some epithelial tissue. And if you look at the very bottom, you can actually see some slough. And then the picture on the lower right is what we would call a DTI. This looks like a bruise, but it's not actually a bruise. It is a deep tissue injury, and we will discuss that more thoroughly when we discuss pressure injuries. So visual inspection is going to be the primary method of diagnosis, and it may require culture and sensitivity tests if bacteria is suspected, an allergy test to determine sensitivity to one or more allergies. A Woods light examination will use a black light to help identify certain fungal infections. A potassium hydroxide test can identify fungal infections that are not observed with the Woods light. Fungal cultures may be necessary to determine the type of fungus that's causing an infection. And skin biopsy would involve the removal of tissue for microscopic examinations. There's 3 methods of biopsy. We can scrape the lesion with a scalpel or a razor. We can excise part or all of the lesion with scissors or a scalpel. Or we can use a punching instrument to remove the core of a lesion. There's several therapeutic measures. Drug therapy would be the first, and there's a multitude of medications that can be applied topically or administered systemically. Standard precautions have to be observed in application of topical medications over any impaired skin. Dressings should protect the wound. They need to retain surface moisture. There's 4 basic types. We have wet, dry, absorptive, or occlusive. And the key to choosing a dressing would be selecting a dressing that has to be changed as infrequently as possible. And if the wound is wet, we would dry it out. If the wound is dry, excuse me, then we need to add moisture until you reach that perfect moisture balance. We can also use negative pressure wound therapy, also referred to as a wound vac. This reduces healing time of traumatic wounds, dehisced surgical wounds, pressure and chronic ulcers, and helps manage wounds that have a heavy drainage. With therapeutic baths, we don't encourage the use of soap, but there might be various medications or oils, such as oatmeal, cornstarch, baking soda, or a mineral oil added to the warm water. However, adding oils to water can create a significant safety hazard. This can provide inflammation and itching relief and also aids in the removal of crusts and scales. Surgical excision will remove skin lesions using laser therapy, in which it's important to protect the eyes and take measures to prevent fires and burns. Cryosurgery, which applies sub-freezing cold to a lesion. Electrodissection, which would use electrical energy to help remove superficial lesions. Radiation therapy, which treats malignant skin lesions. Photochemotherapy uses ultraviolet lights and chemicals to destroy cells. Now, lifestyle changes can improve some skin conditions. If we're tired or we have a lot of emotional stress, that can aggravate some skin conditions. So rest, sleep, and diet are important factors in treatment. And nutrition needs to include maybe small frequent meals to increase caloric intake. Increased protein to promote healing. Enteral feedings if the client is unable to take in appropriate nutrition. Protein supplements and vitamins A and C. Zinc might also be required to help improve healing measures. Changes in the skin are probably the most readily recognizable of all signs of physical aging. We see wrinkling as a result of thinning skin layers and degeneration of elastin fibers. Sweat glands decrease, but production does not change much until advanced age. Sebum production will decrease, and it's apparent earlier in women than in men. Dryness and pruritus are common. The skin will pale because of the decrease in the number of cells that produce melanin. Skin lesions are going to be more common. We see lentinges or liver spots on sun-exposed skin. That senile purpura, which are those purple bruises that the older adults get that seem to come from nowhere and take forever to go away. They come from minimal trauma and resolve so slowly. Senile angiomas are bright red spots. Seborrheic keratoses are lesions that will vary in size and they can be flat or raised. Acrocordones are skin tags. And by the age of 50, nearly half of older adults are going to have at least some gray hair. Men begin to lose hair from the scalp in their 40s, and by their 80s, many are almost bald. And women will frequently have thinning hair. Women will also have an increase in facial hair, but everyone will have an increase in hair found in the nares, the eyebrows, and the helix of the ear. The nails will flatten and they'll become dry, brittle, and discolored. And the risk of premalignant and malignant skin lesions are also going to increase with age.